Hello, welcome. So we're going to go over last week's lectures, diseases of renal vasculature, and then the pharmacology for the renal vasculature. Okay, so let's look at the topic. So we're going to kind of look at an overview. I'm going to pull up some histology, kind of give you a background, and then we're going to talk about some of these diseases. And here I've got them listed. So let's look at the renal vasculature overview. I'm trying to make it a song. Okay, kidney structure. We've got the cortex, which is for filtration. And then we've got the medulla to concentrate. We've got the major and minor calyces. So here is our minor, and it comes to form our major. And then we've got our renal pelvis that goes out to our ureter. Our medullary rays are going to be like when they're the straight tubules, but it's where the glomeruli are high up in the cortex. And then the tubule, here we go, here's a better picture. And then the tubule is going to be in the medulla. The columns of Burton are going to be opposite of the medullary rays. So you can see right here the rays or right here. Okay. Vasculature. So the kidney doesn't have any other circulation besides what our arterioles right here and venules. So if, like other things in the body, if there's collateral circulation, if one vessel is blocked and can't supply blood, then another vessel takes its place and provides blood to that area. But the kidney is not like that. If there's irreversible ischemia, we can't fix it, then the whole section becomes infarcted. And so if we look at this right here, this is dead tissue where that's happened. It's going to be a coagulative necrosis. So the architecture will be there, but there's not going to be any blood flow. And you can see that it's a wedge shape from that coag necrosis. And it'll be pale. Okay, so with hypertension, I think Dr. Yantz calls the kidneys the wimp organs. So he calls them the wimp organs because they're just really particular. They like their pressure at a certain type. They're going to do everything in their power to be able to preserve themselves. So due to the high pressure in the kidneys, it's going to either because of kidney disease or some other cause of hypertension, you're going to get pathological changes into the vessels. So it's going to happen everywhere in the body, but we're just talking about the kidneys right now. So you've already had neuro, so you know how it can affect the brain and cause those lacunar infarcts. But here in the kidneys, the vessel changes can either be benign or malignant, and they are one of the leading causes of end-stage renal disease. And so we'll talk about later, like staging of kidney. But we've already talked about the GFR. So if our GFR is really, really low, like basically 0 to almost 0 to 10, like 0 to 15, we're going to have end-stage renal failure and then have to get dialysis for our patient. Nephrosclerosis is like atherosclerosis that you've talked about. It's going to be hardening of the walls of the small arteries and arterioles. And so basically the lumen is going to be narrowed and there's not going to be a lot of blood getting there, and there's going to be chronic ischemia, which will scar the kidney. Okay, benign nephrosclerosis is going to be hardening of the small arteries and arterioles that have prolonged and gradually gotten worse. It's not going to necessarily progress to chronic kidney disease or kidney failure. If it does, it's going to be either somebody that's African heritage, somebody that has really bad high blood pressure, or somebody that has diabetes. So here's our arteries, and then as they get smaller, there are arterioles, just to remind us. So let's look at benign nephrosclerosis. Maybe you remember back into last year into a gross anatomy days, and maybe your donor or some other donor might have had a kind of a leathery surface to their kidney. So our normal kidney looks like this. And if that like kind of grainy, leathery kind of feel to the kidney, that would be benign nephrosclerosis. So it'll be either normal or a little bit smaller. And it's going to be granular because of these small scars. And then big scars can also occur. But I would kind of think about these like small granular scars. Okay, so here's our pathological changes to the arteries. We're going to have medial hypertrophy. And this is the things that I would remember for this. We'll have medial hypertrophy, and then we'll have reduplication of the elastic lamina. And you can see these like wavy lines, so that's our elastic. And it's going to increase the myofibroblastic tissue in the intima. So those are things that I would probably know. Okay. With benign nephrosclerosis, this is the thing that would be the most high yield to remember. I would know this picture. Notice that it's very pink. And so what happens is there's going to be arterial endothelial injury, causing hyaline arteriolosclerosis. And so these plasma proteins are going to seep in and increase that smooth muscle matrix synthesis. And so this is called hyaline arteriolosclerosis. So know that that is with our benign nephrosclerosis. It's narrowing of that lumen, and a way you can describe it would be glassy, translucent appearance. Okay. So we've also got patchy ischemic atrophy with tubular atrophy and interstitial fibrosis, and the glomeruli are going to be fibrotic and become totally sclerotic, which is just replaced by collagen. So here's our normal glomeruli, and so we can see that it's sort of patchy. Let's make this bigger. Okay, if you can tell, now it's like zoomed in so much, you might not be able to tell. But here's normal. Then we're getting like more pink. You know, you can see there's less of that white right here. And then as it totally hyalinizes, we're like totally pink. So if you think about, look at this, and now we're gonna go back to the last slide. This is like up close. So think lots of these ends up looking like that. So no, benign nephrosclerosis, it's got the grainy looking outside, doesn't necessarily go to CKD, and it's got these hyaline arteriosclerosis. Okay. We see the glomeruli, pink. All right. Scarred areas are going to take a linear pattern, So you can see it's like a line that goes across. And this is with this Mason's trichrome stain. So it's going to stain, instead of that pre-pink, we're staining blue. Malignant hypertension and malignant nephrosclerosis. So you've already talked, I think it was your last exam in cardio, you talked about hypertension. And so you talked about malignant hypertension. And so our malignant hypertension is a systolic blood pressure of over 200 and diastolic over 120. And we're going to have some changes. So renal failure, retinal hemorrhages, with or without papilledema, hypertensive encephalopathy. So we'll have like an altered mental status, visual impairments, and then cardiovascular abnormalities like infarct, ischemia, heart failure. So the kidney part is our malignant nephrosclerosis due to that high blood pressure. And it's either from that malignant or accelerated hypertension. So the path is not super clear, but it's probably from vascular endothelial injury. And the changes result in a luminal narrowing or thrombotic occlusion, causing that poor perfusion, resulting in ischemic kidneys, causing the RAS system to increase. Let's look at this. We've got small pinpoint hemorrhages. So you can see these, if you get up close to this picture, you can see all these little red little lines, little hemorrhages everywhere. And then we get fibroid necrosis, which is swelling of the vasculature intima and intravasculature thrombosis. And so we see those eosinophilic granular changes with a little inflammation, and they become necrotic. So we can see this. So remember, fibroid necrosis with malignant nephrosclerosis. With our benign nephrosclerosis, we had the hyalinization. And then fibroid necrosis with malignant nephrosclerosis. So besides fibroid necrosis, we also need to know that there's going to be this onion skin lesion with our hyperplastic arteriolosclerosis. Due to that hyperplasia of the intimal smooth muscle vessels. So no, fibroid necrosis with onion skinning goes with our malignant nephrosclerosis. Here's our hyperplastic arteriolosclerosis, and we've got that onion skin appearance again, and that again they go with our malignant nephrosclerosis. These words are hard. Okay, renal artery stenosis is going to be a secondary cause of hypertension. So we're going to have a ramped up RAS system, and we get low perfusion. So blood can't get into the kidney because there's something blocking it. Women in their 20s and 30s might get, which is also called the third and fourth decade, which is like sort of confusing. But if you think about it, like when you're 0 to 10, that would be the first decade. Okay, so let's say like you're 20. We'll just say like you're 25. So that, just to explain this, just in case your brain's fried from med school. First decade is like from 0 to 10, then from 10 to 20, then that is going to be the second decade of life. And then 20 to 30 is third decade of life. So your 20s is your third, fourth decade is your 30s. So just in case struggled with that. Okay, so we're going to have narrowing of the lumen due to fibromuscular thickening involved in the layer of the artery. Okay, gross findings. So here we've got our normal kidney, and then we also have this little bitty kidney. So what's going to happen is there's going to be diffuse ischemic and atrophy. So it'll atrophy after that. So there's not a lot of blood getting there. It's not getting a lot of use, and so we end up using this kidney instead. And so you'll see that contralateral kidney shows changes in the consistent severity of hypertension. So low blood flow to our smaller kidney with that stenosis, and the kidney gets smaller to compensate and starts scarring. RAS decides to ramp up because it's trying to compensate, and then it starts hurting our normal kidney. That normal kidney senses sodium coming in, and it pulls sodium and delivers it to the macula densa to decrease our RAS. So it does its own mechanism. Let's talk again about fibromuscular dysplasia that is normally in women in the 20s to 30s. It's not really known the etiology, but it's not really inflammatory. It's not atherosclerotic. It can affect either the intima or media or the adventitia, but most likely it's the media. Complications are going to be severe stenosis, dissection, and aneurysm thrombi formation. So the vessels should be straight coming into the kidney. I don't have a great picture that's just a normal one, but like if you look right here, they're straight coming in. But these kind of look like beads on a string. Now she can't say beads on a string or pearls or anything like that, but you can see that it looks like that. Dot, 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 dot. Okay, bilateral renal artery stenosis can cause chronic ischemia with renal insufficiency, but for it to really make a difference, it's got to be about 75% stenotic. Okay, to review, fibromuscular dysplasia, beads on a string. Renal artery stenosis, we get a tiny kidney on our stenotic side. RAS goes up, normal kidney senses that sodium, decreases RAS. Malignant nephrosclerosis, we've got that onion skin lesion, and we also have our fibroid necrosis. Our benign nephrosclerosis is going to look kind of grainy on the outside and then have that hyaline arteriosclerosis. All right, we're almost done. Let me get okay. Atheroembolic renal disease. This is going to be fragments of ruptured plaques that embolize, and it can go and get stuck in the kidney. It can cause acute renal failure or renal infarct, and so you can see these are like super. I think this one's like really easy to point out because they look like little shards of glass or something in there, and it's fragments of plaque. So it's the embolism that travels and hurts the kidney. A renal infarct, we had talked at the very beginning about like a wedge coagulative necrosis. This part, look, it's affecting all the way to the outside. It's susceptible to that infarct because it gets a fourth of the cardiac output. So either thrombosis or emboli that travel can affect the kidney. And it's going to look more pale looking, like we had seen on that first slide. The gross morphology is going, we said was going to look pale, and then that coagulative necrosis again. Okay, thrombosis. So this is seen in nephrotic syndrome. It's when your glomeruli don't filter, and we've got protein that's going to leak into the urine. So we had talked about it before that we would learn about nephrotic syndrome. So just know that nephrotic syndrome is defined by 3+ protein a day in the urine. You'll see low albumin because what happens is albumin is like a type of protein, plasma protein, and a person's peeing it out. They're not able to filter any protein, so it goes out in the urine. They're going to have high cholesterol because there's no protein to carry it, and there's going to be edema. So our renal vein thrombosis is pretty important. The patient is going to present with hematuria, so blood in their urine. They're going to have flank pain and rarely a lumbar mass. So if I hear hematuria and flank pain, thinking back to last exam, I would think they got a kidney stone. But if I feel a mass on their back, that's pretty abnormal. However, normally they, like on exams, they probably have hematuria, flank pain, and lumbar mass. But on like in real life, they probably don't have any symptoms whatsoever. But they'll have a lot of protein in their urine. Okay, HUS versus TTP. So you've had these in hematology, but now we're talking about it a little bit in renal. So with HUS, it's associated with bacteria like Shingle-like toxins. So our E. coli 0157H7. And then that toxin is what causes the endothelial injury. Or it is, that's what usually with children. In adults, it could be deficiency of complement. TTP is going to be that inherited or acquired deficiency of Adams 13, which is that plasma metalloprotease that regulates von Willebrand's factor. And it causes platelet aggregation and thrombi. And so the neurologic problems is going to be the dominant feature. So renal failure is usually more in HUS than TTP. And remember, like in TTP, they've got the purpura too as well. Okay. Schistocytes is, or the helmet cells, if we look at them here, they are common in a blood smear with somebody with microangiopathic hemolytic anemia. And that's usually caused by TTP, HUS, and other things like DIC. Here's what it looks like. Gross changes, we've got diffuse cortical necrosis and petechiae. You can see the petechiae, the dots. Okay. And then microscopically, we see that fibroid necrosis. Remember that our fibroid necrosis was with our malignant atherosclerosis. And this is fibrin staining red in the glomerular capillaries. And this is our fibrin stain, showing our fibroid necrosis. All right, that's all that lecture. So now we just have Pharm to talk about. Okay, so here's my list. So this kind of has like a review of our hypertension. So we have our ABCDs of hypertensives, our ACE, ARBs, that's our ACE, B, beta blocker, C, calcium channel blocker, and D, diuretic. Remember that usually 140/90 indicates hypertension, and this can affect our kidneys. So our preferred combos of drugs are going to be ACE inhibitors with a calcium channel blocker, or ARB with a calcium channel blocker. ACE inhibitors with diuretics, or ARBs with diuretics. So here is like just a little review of our determinants of hypertension and how that our cardiac output and our SVR is going to affect our blood pressure. So we're going to start with just normally what we do, and then some other things. So first, we're going to start with our lifestyle changes. So we want to limit salt intake, as well as which would be a good heart healthy diet, like the DASH diet. Always exercise, all of the good things. Lose weight, stuff like that. So always start with that first. And then after, so basically, white male, female, less than 60. Start with an ACE or ARB, and then we're going to add a calcium channel blocker or thiazide if it's still bad. So we have a blood pressure of, let's say, 145/90. Then we're going to just give them an ACE or ARB, tell them to eat well, and go home. They come back, we check their labs, and we're going to check their blood pressure. If it's still bad, we're going to add that calcium channel blocker or thiazide. If the blood pressure is 160/100, we're just going to go ahead and be like, well, I don't think this just an ACE or ARB is going to fix you, so we're going to go ahead and add that combo with the calcium channel blocker or thiazide. Let's say we just picked a calcium channel blocker. So we've got an ACE and ARB. We've got an ACE or ARB. We already had the calcium channel blocker, and then we'll just also add the thiazide. Okay. If a patient is pregnant, 2 good drugs to use. There's actually 3, but in this lecture, I think we talked about 2. Methyl-dopa, it's an alpha-2 agonist, and then labetalol, which is alpha-1 beta-1 antagonist. Those are good to use because we've got, I'm pretty sure we'll talk about those, but we've got some problems with the other ones. They can hurt the baby. So treatment of elderly, sometimes elderly patients present with only isolated systolic hypertension. So we're going to just start with a calcium channel blocker like amlodipine or nifedipine. If we need to add something else, we can add an ACE or ARB. In African Americans, that's the AA is for I ran out of room. So that is going to be, they have a low renin pattern usually. So they're going to be less responsive to ACE and ARBs. So instead, we're going to start with a thiazide or a calcium channel blocker like that amlodipine nifedipine. Here's some other indications to use these and contraindications for these drugs. It's nice to know. Okay, so our direct renin inhibitors. So we're looking at this chart. We've got angiotensin down to Ang1 to Ang2 to our AT1. So we've got our DRI, which is opposing renin, ACE inhibitors, which is stopping, of course, ACE, which increases our bradykinin, and then our ARBs prevent Ang2 to go to our angiotensin 1. AT1, sorry. So we, our direct renin inhibitors might produce hyperkalemia, just like our ACE inhibitors, and a few more drugs we'll talk about. So don't use in combo with an ACE and an ARB because it can cause renal failure or too low blood pressure. It's going to act on our local regulators, our circulating regulators, our tone, and our sodium water retention. I don't think they're as important. They're not prescribed as much. We'll start with ACE. That's the main one. It's our first line of treating hypertension. So it's going to decrease the sympathetics, the tubular sodium and chloride reabsorption, potassium excretion in water. It's decreasing all of that. And it like continues on. So you can read the rest of these. Make sure that you avoid in renal artery stenosis. And I've got a picture right here. Okay, so we've got our NSAIDs that are going to constrict our afferent arteriole, and then ACE and ARBs constrict our efferent arteriole. So remember, like if we're at a party and this is constricted, it opposes the constriction. So if we have a really open tube right here, we've got people in our party coming in, and then they just leave out the back door instead of the side door, our GFR is going to go down. So you can see right here, as it's vasodilated and efferent arterial, our GFR decreases. If we combine an NSAID, which is going to decrease the size of our afferent arterial, decrease blood coming in, and decrease our efferent arterial, we're not getting blood anywhere. And so, we're increasing our efferent arterial. So not a lot coming in here, a lot coming out. Our GFR is going to be like super bad. So it's going to be really bad in renal artery stenosis. Okay. So back. So make sure you avoid those, our ACE and ARBs and renal artery stenosis. It's going to act on circulating regulators, local regulators, and our venous tone. So our advantage is there's not going to be a lot of electrolyte imbalance. And it's pretty safe in diabetics. In asthmatics, it's actually like great for diabetes. It protects the kidneys. Our interactions with NSAIDs, not good. Not great with potassium sparing diuretics or supplementation or antacids. Can't use it in pregnancy. Don't want to use it if we already have high potassium or if we've got renal artery stenosis. Remember that with ACE inhibitors, they inactivate our breakdown of bradykinin. So patients that have that start developing a cough, you're going to want to switch them to an ARB. And then patients that have start developing like swelling of their lips and their mouth, then of course angioedema, we don't want to do that as well. So we switch them off of that. Okay, ARBs. So they're not blocking that breakdown of bradykinin, so they're okay to use in those conditions, and they also you can't get that cough. So some physicians are actually starting this as like first line instead, like just like FYI, to know in the back of your mind for like the future. So, but first line is still ACE inhibitors. So these basically do the same thing, except we just don't have those two side effects. And they end with sartan. These ACE inhibitors end with pril or Prelot, mostly pril, like lisinopril. And then like sartan, like losartan. Okay. Beta blockers. We're decreasing our heart rate, stroke volume, contractility, cardiac output. Decreases the renin to the kidneys. The problem is there's a rebound hypertension, could have a heart block, and you can't use in COPD or peripheral artery disease. Calcium channel blockers decrease heart rate and cardiac output and decreases the contraction in the blood pressure. Our DHPCCBs, which is going to be our ipines like nifedipine and lodipine, they're going to decrease our SVR. And it's good in that systolic hypertension like we talked about. Okay. we've talked about a little bit our alpha-1 antagonists, our zosins before. So like prazosin, alpha-2 agonist, clonidine, methyl-dopa. They're going to act directly on innervation and circulating regulators. Labetalol, we had already talked about. It can be used in hypertension in pregnancy or an emergency. See right here, labetalol, alpha-1 beta-1 antagonist. Okay. Diuretics are going to act on the kidney either at one of three places. So we've got our thiazides, and they're acting at the distal tubule, and they're good for African Americans. They can cause hypokalemia. They can cause hypouricemia. And they also can increase your calcium. And you don't want to use with another antiarrhythmic that prolongs that QT interval. Loop diuretics act at the loop. Again, hypokalemia with them. And they're going to also decrease calcium. So hypocalcemia. So know the difference. Hypercalcemia with thiazides, hypo with loops. And they're volume-based hypertensive agents. Spironolactone is going to be a potassium sparer. So we're going to have increased potassium. So that's not good to use with something like an ACE or ARB that can also increase our potassium. And so if a patient has like hyperaldosteronism, somebody with low potassium and really resistant hypertension, that would be good to use for them. Okay. Potassium channel openers would be like our hydralazine and minoxidil. They're going to enhance that potassium efflux and decrease calcium reentry. Minoxidil can be used with severe hypertensive resistant to other drugs, and hydralazine is another safe one in pregnancy, so I could have added it. I should have added it here. So there's our hydralazine. He didn't have that one as like super important, so that's why I didn't include it. But I would know that one probably too, just in the future. Okay. And then minoxidil is like Rogaine that you use on your hair. That's in the like liquid form, just fun facts. So hypertensive emergencies, we kind of had talked about the kidney part. So treatment is going to be our ipines, which are peripheral vasodilators. Also sodium nitroprusside, which is a potent increase in our preload and our potent preload and afterload reducer. And then also labetalol. So no, our nifedipine, amlodipine, sodium nitroprusside, and labetalol. All right, that is it. Does anybody have any questions? All right, then have a good night.